realize we were going to have such a large group. So I was hoping that this could be somewhat informal. So if you have any questions, feel free to ask. Otherwise, we'll have time for questions at the end. So I was asked to talk a little bit about back pain, particularly in women, and things that cause it and what we can do to treat it, or what you can do sort of to help yourself as well, and some of the options that we have for treatment at Cornell. So let's get started. So first, I'm just going to give a little bit of an introduction to low back pain, talk a little bit of the anatomy of the low back, and I'll talk about a couple of different diagnoses that are pretty common, that most people have probably heard of before, or if you haven't heard of, maybe you've had it yourself. And then finally, what can we do about it? So first of all, we call the low back the lumbar spine. So you may hear your doctor talk about the lumbar spine. It's just what we think of as the low back. And what is the low back? Well, it is made up, our spine is made up of a vertebral column, which is made up of bones that go from our neck down to our sacrum. So all the way up here, this is our cervical spine, we have our thoracic, and this is the part that we're actually talking about here, which is the low back and the lumbar spine. And what does this do for us? Well, it provides support for weight bearing. It provides flexibility for movement, so it allows us to bend forward, bend backwards, rotate to the side, and bend down sideways to pick something up. We also have a number of muscles that make up the low back and that support those bones that I just mentioned. So a number of muscles that I'll just briefly talk about. The first one is the latissimus dorsi, and this muscle is one that you maybe, if you go to the gym or you know someone who goes to the gym and does something they call a lat pull down, where they're doing something like this exercise, that works that muscle, which is kind of surprising because you're using your arms. Well, this muscle starts down by the sacrum, which is kind of at our bottom of our spine, and goes all the way up and attaches actually onto our arm. So that's part of the low back muscles. We also have a number of deep back muscles. This picture is if I would have cut someone in half, kind of like a loaf of bread. So going from head to foot. And this is the front, this is the back, and as you can see, this is where the bones would be, and all this area surrounding is muscles. So we have to have those muscles to support our spinal column. So the latissimus dorsi I just talked about goes all the way up and attaches onto the arm, all the way from the bottom of the spine. So it really spans the whole thing. If you take away some of those top muscles, we have some of these muscles here, which we call the deep back muscles. And it's interesting here because they start all the way down at the base of the sacrum, which is the part we call the coccyx, and it goes all the way up to the base of the skull. So to me, that's really interesting that you can have muscles that span really the length of your entire spine. And that comes really into play when we talk about treatments. Even deeper than that, so this is just simply a picture where I've taken off those muscles that I just talked about. And now we have muscles that start all the way down here, again at the coccyx and the base of the spine, and they attach here at the lumbar spine, or the low back. And this provides what we call segmental instability, which again will be also important in some of our treatments. And then finally, some of the muscles that connect to our ribs even. So this is the area we call the iliac crest, which is what you sort of think of as the top of your hip bone. And the muscle that connects your hip bone essentially to your ribs up here spans the course of your lumbar spine. So again, another really interesting muscle that is going to come into play with some of our treatments. And I think this is the last muscle that I'm going to talk about. This is called the iliopsoas. And again, kind of an interesting muscle where it starts all the way up in the the top of the lumbar spine, and attaches down below your hips. So this muscle acts to either bend your body forward or bring your leg up and flex your hip. So all these muscles can affect your low back and can be a source of pain, or can also be a source of treatment that we can offer. So what about the joints in our back? So we have something called a facet joint. In between each of the levels of our vertebral column, each of the bones, so this pink one here is a bone, and then the purple one below is a separate bone. So in between those, you can see this is kind of blown up. There's a joint between those, and what this joint allows us to do is to either flex forward, backwards, rotate, or side bend. And over time, these can become arthritic. So arthritis is something that we'll talk a little bit about, specifically with facet joint pain. So this is one of our first diagnoses that I'm going to talk about. So you may have been to your doctor before, or had an MRI or an X-ray, and they say, well, you have degenerative joint disease. Well, what does this mean? It sounds very scary, right? It's degenerative, it's a disease, but really it's not that bad. All it means is a little bit of wear and tear, a little bit of the bones have rubbed together, and essentially have built more bone on top of the original bone, and so that joint just has a little bit more trouble moving together. But what can it do? It can cause you pain, and it can cause a significant amount of pain. So how did this happen, right? So you think, well, did I do something? Did I pick up something wrong when I was a teenager, or when I fell off my bike when I was 5 years old? Did this cause it? Well, no. Part of it is some genetic factors. Part of it is biochemical factors, just the type of inflammation that your body may have. And part of it is just the wear and tear of your day-to-day movements. So what we like to sort of say is that essentially arthritis is somewhat like the gray hairs of the back, which everybody gets. So, well, I'm confused now because you tell me these joints are in my back, but I have pain in my butt. So is this something that could be causing a pain in my butt? Well, absolutely. So all of these little colors here are actually pain patterns that the lumbar facet joints can cause. So you may have pain, kind of in this area of the low back, or you may have pain all the way down into your legs. All of this can be caused by the same thing. So now, what can we do about it? Well, we're not talking about surgery here, so you can just kind of relax and put your mind at ease. The best thing for this is actually going to be a rehabilitation program. So in instances where you have sort of acute pain, we like to get your pain down with what we call relative rest, which doesn't mean that you lay in bed for weeks at a time. It essentially means that you kind of take it easy. So what that means is kind of for a couple of days, maybe you don't lift things, maybe you don't, stand all day at work, or sit in your chair all day at work. You maybe take a day or so to just take it easy. Medications that we can give are some things like over-the-counter anti-inflammatories, things that you think of like Aleve, ibuprofen, Motrin, even things like Tylenol. And then finally, so a rehab program. And what we would do is we'd work with you and with your therapist to come up with a program that is going to strengthen some of those muscles that I was talking to you about earlier. So some of the things that will come into play in terms of the rehab program will be stabilizing your lumbar spine with those muscles, core strengthening, which I'll talk a lot about today, hamstring flexibility, which is the muscles in the back of your legs, and then things like proper body mechanics when you're working, sitting at a desk, sitting in a car, things like that, some manual therapy, and last of all, but somewhat most importantly, is aerobic conditioning. If those things don't get you to where you want to be, if they don't get you to 100%, we have other options. So while this may, look very scary here, it's actually a very simple procedure. So what what this is a facet joint injection. It's a corticosteroid, and we just put a little bit of this medication into that painful joint. So, do you have to have this? Well, we don't know. We have to see you in the office to find out. There's other things we can do. This is something we do in our practice. It's called a medial branch block. And essentially, it sounds very, fancy, but all we're doing is numbing up the nerves that supply that joint. So all joints get their sensation from nerves. So when we numb those nerves up, you wouldn't feel the pain coming from that joint. So that's one of the procedures that we can do in our office. It's actually fairly simple. Both of these procedures that I just mentioned take about 15 minutes, and you don't have to be put to sleep. They're relatively painless, and you walk out and you go back home that day. The next topic that I'm going to talk about is compression fractures. So I see a lot of people in this room that are of the age where compression fractures tend to happen. In general, a compression fracture is the most common sequelae of osteoporosis. So I won't have everyone raise their hands, but I can guess probably about 40% or so of you in here may have some osteoporosis. It directly correlates with increasing age, and then also just the incidence of having osteoporosis. Generally, it's women in their 50s and 60s, and then it goes up from there. So 70s, 80s, 90s, 100s. People tend to get more compression fractures as they age. So what does it feel like if you get a compression fracture? What do you know? Well, it could be pain in your low back, and it could be either acute. All of a sudden, one day, you bend over to pick something up, or you take a fall, or you just get out of bed and you have this sharp pain. Or it could sort of slowly come on over time, and you don't really notice it until one day it's really causing you pain. It's usually worse when you're sitting down, when you're standing or walking, and even sometimes when you're turning over in bed, it can be really painful. It usually feels better when you're just kind of lying down flat because you're taking the pressure off the spine. Sometimes people have difficulty bending forward because if you kind of remember this picture here, this is the front of your spine, so where your belly is, and this is the back. So what happens is, as you compress down onto this bone, it just sort of smushes a little bit. And so what do we do? Well, we order an x-ray, and this is what we may find. So what we look at on the x-ray is, we like to see that these spinal vertebral body bones are nice and square. And as you can see, these are nice and square until we get to this one, and this doesn't look so nice and square anymore. So what do we do about this? If you get a compression fracture, also not the end of the world. So first thing we want to do is control your pain. There's a number of different options that we have for that, and in this case, we definitely don't use anti-inflammatories because we want to make sure that the bone is going to have good healing. So in that case, we'll use different medications. Initially, you may take a couple days in bed, but really we like to have you up and moving around, and I think that's going to be sort of a general principle with all of these diagnoses is that we want you still moving around. The worst thing you can do for yourself is to just lay around in bed. Things that we'll do in the rehab program will focus on bending backwards in the spine, and we may even use some bracing to keep you from bending forward, to prevent you from having pain and to prevent it from getting worse. And then we may address, actually we will address your osteoporosis if you have it. So we'll maybe do a couple of labs, take some blood, and check out your overall bone health. The next thing I want to talk about is the intervertebral disc. So this is something that I know everyone has had a friend or a family member or themselves who has a herniated disc, right? So what exactly is that? What does it mean? What can we do about it? Well, I like to think of the intervertebral disc as a jelly donut, okay? So here we have this nice, delicious looking jelly donut that is kind of harder on the outside and firm, and it keeps its shape. And then as soon as you open it up, there comes the jelly kind of spilling out any of the sides, right? So this picture on the right is a picture of the discs. The discs separate the bones in your back and give mobility to the spine. So our disc is sort of surrounded by this layer here, which is kind of like a ligament, and provides that outer structure of the jelly donut. Whereas the inside, this nice little jelly here, isn't so strong. And when you have some disruption of the ligament on the outside, sometimes that jelly can kind of push out. So why do we need these things? What do they do for us if they're going to cause us pain? Well, they bear weight when we have compression through our spine, and we sort of, through physics, transmit the load from the inside of the disc to the outside, which makes us more resilient. So what happens if something happens to your disc? Well, you may have, and you're going to start hearing these things over and over again, low back pain. So there's not a lot of things that may tell you specifically that this is a disc, or this is a joint, or this is a compression fracture. That's my job. So mostly what you may feel is low back pain. You could have worsening pain if you cough or sneeze. If you bend over to lift something, you may feel pain. Or if you do any kind of just twisting activities or lifting things. And you may say, well, what did I do to cause this, right? So why is the jelly donut of mine getting, broken, and my neighbor or my family member or my friend is not, theirs is fine? Well, really you did nothing. So you can't blame yourself for this. There's nothing that you did. It just is a matter of aging. So generally, at about 30 to 40 years of age, the majority of people have at least one herniated disc. So a lot of people are always sort of, very surprised to hear this, because if you've ever been to the doctor and you've had an MRI of your back, some doctors, will say, you have 3 herniated discs. Well, if I see that on your MRI, I can't tell you when that happened, and I also can't tell you that that's for sure what's causing your pain. So if it happened 10 years ago and it's been sitting in your back, we just haven't gotten a picture of it yet. But on the flip side, some of those discs can be very painful. And some of this pain can be associated with pain going down into your leg, numbness or tingling of your leg, or even feeling like your leg is weak. So I kind of went over this already, but essentially this is kind of a picture of what happens. So this ligament gets a little bit of a tear in it and slowly kind of gets larger over time. And the most sensitive part of the disc is the outer 1/3. So by the time the tear gets to the outer 1/3, that's when it becomes really painful. So how do we know if you have a disc problem? Well, besides asking you questions and examining you, there's some studies that we can get, and this is a picture of an MRI. So here is what we call a sagittal MRI, and what I'm doing is I'm looking at you from the side. So if you were standing up and I'm just looking directly at you from the side, I look and see there's a little arrow, actually, you can see here, a black arrow pointing to a disc. We like to see that this is nice and sort of congruent here. It just continues down in a nice line. And as you can see, there's a little bit of an outpouching here, and that's the disc bulge. In particular, in this case, it's something we call an angular tear, and this is what's actually causing the pain in the disc. It has nothing to do with how big it is, where it's pushing, anything like that. It all has to do with that ligament that got a little bit torn. So I think this is actually very interesting and has been sort of quoted in a number of studies, that this is essentially the positions that you could possibly be in and the pressure that they cause on your back. So for example, this is someone laying on their back, and The disc pressure is 25. This is someone standing up straight, and you've got 100. Now if you look all the way over here, this is someone sitting down, right? So it's really counterintuitive because you think, well, if I'm sitting down, shouldn't that be taking pressure off of my back? But not really. So again, that kind of comes into play when we talk about treatment and also prevention. So I talked a little bit about disc tears, and now I'm going to talk about what happens when your disc actually herniates. So we saw a picture similar to this before. This is our nice disc before with a little bit of a tear in it, probably causing you some back pain, but not likely much else in terms of weakness or pain down your legs. Until something like this may happen where that jelly material pushes out a little bit further. So this nice little thing swinging around here is a nerve, and what's pushing in there is the disc material onto your nerve. So this is kind of what we think of when we say you have a pinched nerve. So what's happening is the disc in your back has herniated, that jelly has pushed into the nerve, and is really just irritating the nerve. And guess what? That nerve goes down your leg. So when you get pain shooting down the back of your leg, the side of your leg, or maybe even into your groin, some of that could be coming from your back. So again, where will I feel this? So besides the back, all of these red areas are areas where you could feel some of this pain. And this really doesn't show up that great here, but essentially this shows even larger herniation than we saw before. But just to give you a little caveat in that I could see a patient who has very minimal pain, like on a scale of 1 to 10, I could see they have pain 2 out of 10, and their back could look like this. Or I could see someone who says, I have 10 out of 10 pain, and their back could also look like this. So it's more, we like to look at the clinical picture, we say, and so your story and your exam, and that's how we make our diagnosis and our treatment. So again, what can we do about these herniated discs? Do we have to have surgery? I think that's what everyone worries about, right? Really, there are very few indications for surgery for this type of diagnosis. Only indications are things like intractable back pain, meaning you've tried every other thing, including medications and therapy, and changing your work environment and things like that. Or things like your leg is getting weak. So that's a neurologic change that we don't want to see. Or things like you're having bowel or bladder changes or difficulties. But so if I don't need surgery for this, then what can I do? Well, initially we want to kind of rest your back. And this is kind of a common theme, I think, that I've mentioned already. The next is sort of pain management. So what kind of medications could we use? Well, again, we could use some of those over-the-counter medications that I talked about, but we could also give you some stronger anti-inflammatories or some nerve medications. And we would talk to you about that certainly in the office. Sometimes we use modalities like heat or ultrasound, but the mainstay of treatment is really rehabilitation. So it's things like strengthening your core, those muscles that I talked about earlier, stretching things like your hamstrings, your quadriceps, working on core endurance. So it's not just doing sit-ups and sucking your stomach in when you think about it. It's holding that in. It's your core muscles are like a girdle if you think about it, and they're holding you up. Another thing we do is we take a look at your ergonomics. So sometimes we'll have you bring a picture of what your workstation looks like. Are you sitting in a way that's going to increase pressure on the disc? Are you reaching for your computer too far? Things like that. And then aerobic conditioning. There's been a number of studies which actually show that aerobic conditioning can be very helpful in the long run for a number of reasons. So that's things like biking, walking, jogging, using the elliptical machine, things like that. So So we talked about this a little bit. Do I need surgery for discogenic pain? Well, my job is to make you not need surgery. So I will do everything I can to not send you to the surgeon unless you really need it, okay? If you do have surgery for something like this, what they're going to do is really go after that part of the disc that was sticking out and kind of, in a very simplified way of explaining it, just cutting that out, essentially. If your pain is really bad, but you're not a candidate for surgery, we have other options for you. If things like therapy and those oral medications aren't working. So we have things like epidural steroid injections, and I know these are very common. People have heard about these quite a bit. Essentially, it's similar to the procedure that I talked about earlier. It looks very scary on these pictures, but really it's all about 15 minutes. We use an x-ray camera to guide the needle so we know exactly where the needle is. And we just put a little bit of medication to take the inflammation away from the